Good evening. On behalf of the Indiana University College of Arts and Sciences, thank you for joining us tonight. I'm Vanessa Clow, and I serve as the college's Director of Alumni Engagement. Our Food for Thought live streaming series serves as an opportunity for our alumni and friends to hear from faculty experts, explore topics of interest, and stay connected with IU and the College of Arts and Sciences, regardless of your location. At this time, I'm delighted to introduce tonight's featured presenter, Distinguished Professor of Sociology and Founding Director of the Ursay Institute, Bernice Pescosolido. A renowned expert on mental health stigma, Professor Pescosolido's research explores how social networks and cultural dynamics shape health, illness, and healing, with a focus on stigma, suicide, healthcare utilization, and systems. Her research has been broadly published across disciplinary and general journals and has been supported by a number of NIH institutes as well as the National Science Foundation and private philanthropic organizations. Professor Pescosolido has served as the Vice President of the American Sociological Association and has received several career, teaching, and mentoring awards. Following her presentation, Professor Pescosolido will be joined by Provost Professor and Acting Chair of Gender Studies and Director of the college's Arts and Humanities Institute, Brenda Weber, for the audience Q&A session. Professor Weber researches discredited cultural texts from 19th century women's literature to contemporary media, examining how identity is constructed through gender, sexuality, race, and class, with themes like celebrity, masculinity, and American religious cultures unifying her work. You can submit your questions at any point during this evening's discussion. Simply click on the Q&A tab located in your webinar toolbar. Hover your mouse over your screen and your toolbar should appear. Closed captioning is also available. Now, it's my pleasure to welcome Professor Pescosolido for her presentation. Thank you.
Thank you, Vanessa. I think often people think of scientists as sort of following a logical path through their careers, but this is going to be one of those stories where you never know what you're going to end up doing because of the needs that other people have and what you can do to help. So let me start off by saying that I had no intentions of studying mental illness. I had no intentions of studying stigma. What I was interested in was the very simple and very general question: how do people respond to crisis? When something happens to them, how do they decide what to do? Do they decide what to do, or are they pushed into various ways of dealing with it? It turned out that one of the most exciting things to me in terms of thinking about this was, what do people do when there's an onset of illness or disease? And so my interest was in studying, how people get into services, pathways to care. And my problem was that the theories that were out there were very elegant. They were very rational. They were all about how people weigh the costs and benefits of their different options. My problem with that as a sociologist was that I didn't know anybody who made their decisions that way. That, from my understanding and observation, that the pathway to care is peopled. You bump into people who help you. Maybe they've had this before, or you talk to the pharmacist. And so I developed this model called the network episode model, which did focus on the power of social connection. And I worked on a number of studies, which was able to show that this way of thinking about it actually had some value to it. But once I did those studies that showed that this is a decent way to think about it, I started asking myself, what's in those networks? And as a classically trained sociologist, my mind went right to Erving Goffman and the idea of stigma. Stigma really is the prejudice and discrimination that's associated with tainted positions or behaviors or people. And, mental illness had been one of the places where this kind of research got started. Erving Goffman himself, who was a professor at the University of Pennsylvania, actually spent a year in a psychiatric hospital in Washington, D.C., and observed what was going on. And he came out and he wrote 2 books on this. One is called The Asylum and the other is called Stigma. So it was, I had the theoretical toolbox that I needed, but I wanted to know what was going on in stigma in contemporary America. Well, when I looked into it, I found out that there hadn't been a national study for 50 years. And I thought I must be mistaken. I'm missing something that happened. So I called a very famous professor at Columbia University and said, Bruce, what am I missing? And he said, nothing. We haven't had a national study in 50 years. So I told him we need to link arms and make that change. And so we did that. But it was hard to actually find the funding from it or for it because there were two psychiatric assumptions that we were battling. One was the American Psychiatric Association's president in 2004 announced that with deinstitutionalization, as we moved from care in long-term facilities to community-based care, that stigma in the US had dissipated. I had just spent 9 months in the two largest psychiatric units in Indianapolis hospitals, and I saw no evidence that stigma had dissipated. So I kept marching with Bruce on this. And I called the NIMH, the National Institute of Mental Health, and I said, we want to do this study. And they said, yeah, we know stigma exists. Send us a randomized clinical trial to change it. And we're like, you don't know what the targets are. So my career took a right turn in terms of the focus on stigma. And it went from a sidebar to a central focus, from a theoretical question to a myth-busting programmatic approach, and from basic science to institutional change. So Indiana University is the home of the U.S. National Stigma Studies. From 1996 through 2018, we have monitored a representative sample of Americans to get a sense of what the cultural climate is around mental illness. I don't really have the time tonight to go into it at all, but I'm happy to answer any questions when we get to the Q&A. But I am really pleased to be able to say that right now we are in the field with the 2024 National Stigma Study. And I think this is really important because I always say that the one silver lining of the COVID-19 epidemic was mental health and the recognition that everybody has mental health and everybody is vulnerable. So we're interested to see if the cultural climate has become more accepting of people with mental illness and kinder and more willing to support the kinds of services that we need. So I was doing these studies, and I teach a very large course called Medicine in America, Physicians and Patients and Their Problems from Genes to Global Cultures. And I was in my office one day and the phone rang. And I picked it up and I heard on the other end of the phone, is this Professor Pescosolido? And I said, yes, it is. And she said, this is Glenn Close. And I thought I was being punked, right? So on the right here are two of the people I went to graduate school with, two of the women that I'm still very close to. And I thought they were punking me about this. So I embarrassed myself a little bit because I kept saying, yeah, I'm sure. She said to me, no, I just read your article in the American Journal of Psychiatry. And I said, yes, I know that that is absolutely a required reading list for people in Hollywood. But she did finally convince me that it was Glenn Close. And she said something very important. She said, I'm tired of going to galas and writing checks. My family suffers from mental illness. I'd like to create a new style organization that is based on two things. One, the family, and two, science. And I knew enough to be dangerous about what was going on in the efforts to change mental health stigma. And this was new and fresh. And she wanted her tagline to be stop stigma by starting the conversation. And that literally came from our research that showed that most of the efforts to change beforehand had really been about trying to convince the American public that mental illness is a disease like any other disease, like diabetes or cancer. You wouldn't tell a person with diabetes not to take their insulin, but just pull up their bootstraps. But we do that for mental illness. The problem was that our 2006 study had shown that Americans totally believe that mental illness is a disease, but it turns out to have nothing. It is not at all correlated or predictive of whether they're willing to accept or reject people with mental illness into the common places in life, as a neighbor, as a friend, as a coworker, as somebody who marries into your family. And this had sort of moved Glenn toward this new way of thinking about it. So I helped her write a speech. She was giving a keynote at the Society for Neuroscience. And then she called back and asked if I would be her scientific advisor. And so for the last 10 or 12 years, I've been the head scientist for her organization, Bring Change to Mind. So I said to her, after I had worked with her for about a year or two, you know, obviously I don't get paid for this as part of our job, our service job as professors. I said, but you know, Glenn, quid pro quo. I would like you to come to IU and speak. At the time, the College of Arts and Sciences had a program called Themester, and we had applied for and been successful to do one of the semesters on networks in a complex world, because that focus on people and connectedness is what really drives my work. And so she did come. And you can see one of the first pictures of her as the students developed a lot of swag and these tank tops to sort of start the movement here on the IU campus. And one of the things that we did was that then First Lady of IU, Lori McRobbie, had a dinner and invited Glenn and a number of really important women from the campus to sort of talk about this idea of mental health and mental illness and how we can change things. And many of you might know that at the time, we had this incredible chef here named David Talent. And so, you know, all the important people were at one side of the room and I was at the other side of the room. And that was fine. Great dinner, you know, nice wine. And all of a sudden I hear from the other end of the table, you can do that, Bernice, right? And I was like, yeah, I can do it. I didn't know what they were talking about, but I figured whatever it was, you know, we could probably handle it. Well, what that was a call for us at IU to develop a program to make campuses safe and stigma-free zones, to really think about how we bring home the research to higher education. And so we began to develop a project. And Glenn was here. She would come and visit. She funded the project, and we got it. A lot of important people at IU were just wonderful at giving us access to things like we could use the Trident if we wanted to. We could send emails out through the Office of Enrollment. These were all really important because it's not just doing the effort, it's doing the science with the effort to make sure that it's working. Okay, so we basically followed. Well, I have to be perfectly honest about this. What we did was, let me go back. What we did was the first year we followed the entering cohort of, I think, 2014, and we made a lot of mistakes. So we restarted in 2015 a project. And the project had to be, even though we were trying to establish the evidence base for how to change things, we didn't just sit around a table and discuss it. We went into the science to find out what could we learn about changing cultural attitudes and climates. And so this was important because the societal landscape of college turns out to be a really important locus for not only is it the time when most people develop a serious mental health problem is between the ages of 14 and 25. So this was really a good time. And we were already seeing that there were rising suicide rates in the United States. We knew that things like COVID-19 and Black Lives Matter, these have all sort of increased the concern that parents, the population has, that faculty had for the mental health of their students. You put that together with the standard challenges of college, you know, new living arrangements, new networks, new expectations. We knew from Project Healthy Minds that there's a high prevalence of mental health problems in college students, about 30%, and that we had not really been doing our job on this. So we knew that it was important. We agreed to do this. We were invited by Cold Harbor Springs Laboratory in New York, which was one of the places they invented the atomic bomb. They had moved to talking about stigma and wanted to help us with this. So our goal was to make college campuses safe and stigma-free zones. And we had clues from science. The first clue came from a study that had nothing to do with college, but it showed that change is most effective if you don't try to change the hearts and minds of people who are set in their attitudes, But if you have a cohort of people, if you can, start with people who are young and get them in the right mindset, then as they grow older, the society will change. And that's called cohort replacement theory. And that time when they are one of those times in the life course when they are very open is when they come to college. And that came from research from the acquired disposition model that said that there are times when people are really ready to look at their values, and college is one of them. We also learned that we shouldn't be focusing just on students. We needed to think of the entire college campus and think of it as a social fabric, and that we needed to sort of integrate changing attitudes, behaviors toward people with mental health problems across all levels. And the last thing we knew was that we needed to have it be sustainable in the long run. And so this involved both students, because really, if it's about them, there's a statement in mental health, which is nothing about us without us. And we took that seriously. So we developed a peer-to-peer program, but it required institutional buy-in, because we knew if the institution wasn't behind it, it really wasn't going to last for very long. So what does this program look like? Well, you start young, which is why every year, thanks to new student orientation, we get to do an event with the entering freshmen. This year, it was the Purple Elephant Project, and the Purple Elephant Project is a squeeze toy that says, "What's up with the purple elephant?" And the event there, what they had to do to get the squeeze ball was to talk about what it was in their lives that they thought might be holding them back. What did they feel might be something that they might be stigmatized for? And they have to write that down on a tile, and then it becomes the mural of the class of 2028. So every year we're able to do that, and starting young is very important for us, right? As I said before, it's by students for students. They come up with some of the weirdest things, but when we ask them, what would you want to do, or what do you want in terms of filling out the survey at the beginning. We were thinking of things like pens and paper and things for their dorm rooms. And they were like, no, we want fanny packs, we want tank tops. And then I asked them if they wanted mood rings, because they had taken me back about 20 or 30 years. What students want is always not exactly in line with the way the faculty or the institutions think. So here is one of the first things that the students designed, which was a bus wrap. And we love this bus. We don't have one right now because we don't have the funds, but we did at the beginning. And what is very cool about this is that this part wasn't cool. It ended me up in the provost's office, because the students wrote this. This is a Richard. Richard tells his friend to when he tells his friend, just snap out of it when she's depressed, Richard doesn't know that this is stigmatizing. Don't be a Richard. Well, this was modeled after some meme on Insta or something that I don't know anything about. But the original last line wasn't exactly "don't be a Richard." And the dean, the provost, said to me, "We can't do that." And she actually came up with the change of this, which was really great. I went back to the students and I said, the provost doesn't approve it. She did come up with a suggestion, and they were like, that's even better, because we'll get it, but you old people, you'll never get it. So it's really interesting to see what the students come up with, and it's not always what you would expect. Okay. And then the other thing that we learned is that the people that we want to come to events are not the people that will come if you say we're doing something on mental health, right? They're more likely to come now than they were in past years. But what we learned is that we needed to bait and flip, which is we needed to have fun things for college kids to do that they would come to do. And then we would embed and kind of sneak in the mental health learning, letting them know what things are on campus that they can do, having them understand about the concept of stigma. And again, you kind of see the kinds of things that they would come up with, bring in the booty around Halloween. It was a scavenger hunt, and every one of the 14 stations was something that they had to do around mental health knowledge or awareness or behavior. We did that about 3 years in a row. It's really a favorite among the students. Okay. And then the idea was mental health should not be put in a corner. It should not be, stigmatized. And so the students will leverage, any other organization that wants to be part of this. And so we had some of the club sports from the rec center come and say, we are a lacrosse club, and we would love to do a game where we represent during October, which is Mental Health Month. We'd like to represent. And so we said, design your shirts and, we'll get them for you. And this was not a home game at IU, but they actually convinced the opposing team, which was University of Illinois, to actually do their own anti-stigma effort as well. And you can see some of the other things that they have provided and the ideas that they've come up with. Everything from designing masks when COVID hit to working with international students in terms of getting the word out. Okay, the important thing about this, we're not the only college program, by a long shot. But one of the things I noticed as a sociologist was that really wonderful programs like Active Mind, which was started out of University of Pennsylvania, everything is online, right? You can get some things for free. Other things are very, very expensive. And we thought we want a different model. And so our model is one that has two different parts. One is that it's high touch, that the program is or would be free to any college or university that wants it, but they have to have an organization of the university, not student clubs. They have to have a place where this program can be located, because we know that without that institutional home, that it will disappear, because we had that experience at first where the students who were our first You Bring Change to Minders, they were great. But when they graduated, the club started to teeter. And so we knew that we had to, rethink our model. The second thing is, we don't want this to be something that we feel we push at people, right? And so this is an evolving library of events. And the buy-in for students is that wherever this is, we send them a bunch of forms that, tell us what was your budget, what was the science on which it was based, and, do a little survey to show us if it was effective. And we create a brochure of that event. And so they can also build in legacy, which is something that I never thought of that when I was in college, but I learned in the last 10 years that this generation cares about leaving a legacy. So we built that into the program as well. And that's important because it allows it to evolve with the students, and it allows them to feel even greater ownership than just running the events. Okay, so just to show you a little bit of the evidence base, because I was really worried when we did the freshman, when we did the survey at the beginning. I know what the national numbers look like. When the numbers came in from the first year students, I was very depressed because it was much lower than the general population, which is a good thing, except if you're doing a program to lower those stigma levels, right? So they were already pretty low, but we surveyed them in their freshman year, right, as they were coming in, and then we did the programming and we surveyed them again in the middle of their junior year. And these are some of the results that showed that not only did we reduce attitudes, but we also reduced behaviors or stigmatizing behaviors. So we had an evidence base that this was something that could actually work. Okay, so I'll just say again that what we learned is that sustainability requires that the institution, buy into it. And so this has two parts. One is that there has to be an institutional home for it that is not just a student club, even though it's buy-in for students. And second, that we take all their information on events that they do, we create these, we make these into brochures, and they get to have their names on this. Like, this was created at IU South Bend, right? Here are the names of the students. And legacy has become important to this generation, which is never something I thought of when I was in college, but they're apparently into this. So let's see. Yeah. Okay. So this is the evidence base. And I was really worried about this because when we first surveyed them as they were coming into IU, their levels of stigma were much lower than the general population. And so that's a good thing, but it's not a good thing if your goal is to mark change in this to see if your program works. But nevertheless, even with those low levels, we were able to demonstrate statistically that we were able to lower stigmatizing attitudes and stigmatizing behaviors. So that was quite good for us. I'm not going to do Christine. So what we're trying to do here is build a foundation for sustainable and improved mental health. And it turns out that when we had finished all this and we were working on this program, President Whitten came in, and she came in with an initiative. She said student mental health is her initiative. And we all dropped everything because she asked us to write some reports. She asked for 3 different reports, and one was culture and climate, which was sort of in my bailiwick, and she asked me to chair that. And one of the things that what has been a result of that is that the You Bring Change to Mind effort is now on all campuses of Indiana University. We now have a powerful partner. We had no idea that the Colts had a philanthropic cause called Kicking the Stigma. It was a result of the NFL telling each of their franchises that they have to pick a philanthropic cause. Now, of course, players have their own foundations, but each one has to pick a larger, cause. So, for example, the Philadelphia Eagles do autism. Our Indianapolis Colts do Kicking the Stigma. And so I eventually got up the nerve to call them and say, do you know we do the national stigma studies down here? And they did not know. And so we began helping them with their project. They have a grant program, which is fantastic for the state. And so we would help them with the grant program a little bit and anything that they asked us to do if they needed information. And eventually I said, we tested this college program down in Bloomington. We should talk about it sometime. And they said, we're interested in funding, what you all are doing. And so we were able to I wrote a proposal that said, how do you change stigma in a state like Indiana? Very little of it was about IU, but I didn't know that their head of philanthropy, Kaylin Ursay Jackson, was a graduate of IU Bloomington, loves IU Bloomington, and picked the 3 things that we had said you could do at IU Bloomington. And so we have built a research institute in which stigma is one of the central things that we research. It's all about the socio-medical sciences. So it's all about how social factors, shape, what we tend to think of as biological processes. But we're learning now that things like, your childhood experiences, your social networks, that these are just as important, if sometimes not more important, about whether you stay healthy or get sick than some of the biological processes. And the point of this was to build a bridge to the medical school so that they could share their medical wisdom with us and we could share our social wisdom with them. So we have a really nice partnership going on with the Colts, and I hope we're doing what they would like us to do or what they expect. So one of the things we've been thinking about now is whether or not IU could be the center of college mental health. Because as I said, this is not for us a business. All of this program could be given to any college or university free. But we need 2 things. The first thing that we need is that the institution has to have buy-in. They have to have someone who's in charge of this in an institutional home. So it has that stability, right? It has that longevity and sustainability. And the second thing is in order for it to be high touch, there has to be sort of an infrastructure that connects all the different colleges and universities, not all the time, but just in terms of sharing information with each other about what the students are doing. And I've never seen anything more powerful than when you bring students from different colleges and universities together and they find their soulmates in terms of their passion. So that's something that we're still trying to do at this point. And I'd like to open it up to questions and answers and turn it over to Brenda. Would you like me to stop the share?
Yeah, probably. Thank you. That was really fascinating. I actually have a number of questions that I wanted to ask, but I invite anybody who's participating, if you have questions that you want to be considered, please put them on the Q&A, and then I will be reading through and asking them of Bernice. So I have a question largely as a gender studies professor, I think, to start us all out. I've got lots of questions because I feel like my job here is to be the super student, and this is not my area of expertise, and it's not my field or methodology because I'm very much a humanities scholar. And yet it speaks to themes and concepts that I'm really invested in and work through a lot. And thank you, by the way, that I had the opportunity to interview Glenn on one of her visits to IU, which was fantastic.
Yeah, was
She
it
did
after?
one of the Jorgensen. She did a Jorgensen lecture for the IU Cinema, and so I had an opportunity not only to talk to her but to zhuzh her hair, which was really exciting.
And that was following the screening of Fatal Attraction.
We watched two things. We watched Fatal Attraction, and then we watched Alfred Nob. And it's actually kind of related to Alfred Nob's that I want to ask the question. So let me give some context for people who don't know this film. I'm guessing you know the backstory for Fatal Attraction, those of you who are here, in that it's Michael Douglas playing a man who has an extramarital affair with Glenn Close, and then she goes off the rails into a mental health crisis and boils his bunny, and it becomes for the moment a really interesting cautionary tale / horror film about mental illness and defying kind of morality norms around monogamy and things like that. And it kind of made her career, I think, in a lot of ways. It kind of fixed her in the cultural imagination. But Alfred Nobs is a film where she plays someone who was born in a female cisgendered body and doesn't really claim a transgender identity, but lives his life as a male in Ireland in a moment where that kind of thing is not acknowledged or accepted. And it was a passion project for Glenn, something really important for her to be able to think through all of the complications and the complexities of that. And that actually kind of speaks exactly to the first question I wanted to ask you, which is, so we're talking about ending stigma, which I'm gathering means sort of negative reactions toward mental health or the need to sustain kind of positive mental health. But what do we do with systemic injustice in relation to mental health stigma? So specifically thinking about gender dysmorphia and the DSM, the Diagnostic and Statistical Manual, which for many, many, many iterations said that, gender dysphoria was a form of mental illness and has created its own kind of stigma, which you can absolutely see in Alfred Nobs. I'm just curious how you make distinctions and if there's a meaningful kind of separation to point to there.
I don't think it's any secret that the DSM has made many mistakes in its history, right? And so one parallel to that was I forget, it was in the 1950s, decided that homosexuality was in fact, in a very Freudian way, a mental illness. And it took a scientist, and it had something to do, I can't remember the exact, I know that the researcher was a woman named Hooker, and she did research that showed that whatever their underlying thing was, it was like something about their fathers or something. And she was able to disprove the underlying logic of saying that homosexuality was in fact a mental illness. And so I think, it's the DSM is one of the most disputed books that exist. And it's not a pure scientific document. The way that it works is they bring together experts on each of the diagnoses, and they discuss and come to a consensus about what the symptoms are for this and what should be in and what should be out. And so a lot of times, as we're able to do scientific studies about this, then we're able to provide the information to get a sense of whether or not what's in the DSM makes sense or doesn't make sense. I think if you talk to most providers, they do not like the DSM because it does that. It kind of puts people in boxes that don't really fit a lot of times what their problems are. The reason it doesn't go away is because the insurance companies need a diagnostic code. And there's that. And then there's the international diagnostic codes, and they're not much better. So it has a long history of making mistakes, particularly on issues having to do with social factors. And we're still worried about it. Like the research that's been done, for example, on schizophrenia, there's no supporting evidence why Black men are diagnosed at 4 times the rate of schizophrenia than any other group in American society. And there doesn't seem to be any genetic base for it, doesn't seem to be any biological base for it, but there's a pretty good social base for it. So, they continue to struggle with this. And as I said, they're going to use it as long as the insurance companies need it. But I think our job as scientists, and I think as humanists, is to really fight those diagnoses that don't seem right. Right. And I think, Glenn has always been a supporter of those. The reason she got into this, I think, is relevant to your question. Her sister, Jessie, was younger, and she was kind of the wild child of the close family. And they just thought, she's this person. But when she was 50, she went to Glenn and she said, Glennie, I can't stop thinking about killing myself. Mm-hmm. And it took another 2 years, but she was finally diagnosed with some kind of glucose-related, very serious depression, and actually a bipolar disorder. And so, for years, her family, as Glenn said, her family had no language to talk about Jessie or Jessie's son, who was diagnosed with schizoaffective disorder. So that's really why this whole idea of family and science comes together for her.
Can you talk just a little bit more about the complications of an invisible disability, particularly in the context, right, in sociology, where in our department of sociology is more quantitative in nature. It's driven by data and all the kind of stuff that I don't do. But I'm curious what kind of special challenges present themselves, given that the very nature of mental illness doesn't necessarily present itself in an entirely legible or necessarily repetitive across all people who experience it in a similar way. It just doesn't always present itself in the same kind of manner. Mm-hmm. And what kind of special or unique challenges does that provide for you as someone who researches these things?
Well, I think ironically that I will say the two ends of the scientific continuum have increasingly been used and help the standard medical model or the standard psychiatric model. And that is that people were looking only at hospital records. They were only looking at people who ended up in hospitals or emergency rooms until social scientists really went out into the community and talked with and lived with and recorded the experiences of people. So, even though my department is highly quantitative, we're also highly qualitative in terms of those kinds of data. And so that has really helped shift the medical model in a way that's really important. And I say we go slide all the way to the other continuum because I was just reading a paper of a group that I work with in Utah, and they're using AI, right, artificial intelligence, to understand why it's so hard to diagnose mental illnesses. And what they found with their deep learning, which I barely understand, is that the problem with mental illnesses is that many of the symptoms overlap between the different diagnoses. For each major mental illness, and they looked at 5 of them, there's a unique profile of symptoms, but the symptoms for anxiety might be some of the same symptoms for depression. But when you look, if you have enough data and you can identify what the unique profiles are in those sort of overlapping categories. So I think from both ends of the scientific continuum, from talking to people with lived experience, all the way to this very foreign to me, deep neural learning, I think we're changing the medical model, which of course was, there was always a battle between the Freudians who said it was all about the moms, right? And the Kreplians who were all about just putting people in boxes. Neither one of them a good idea. But those were the two models that psychiatry had. And eventually the putting them into boxes model won, but they have actually been fairly open, at least many people, to getting information and thinking about it in other ways. So I think, Brenda, part of this came from the number of people who stepped up and wrote books about their own experience or their own family's experience. So I don't take you out of the game in terms of helping us with this problem.
Mm-hmm. I'm going to turn us to some of the questions that are coming from the participants. I want to ask one more question of my own first. So you started off with a discussion on Irving Goffman and then reaching out to a friend at Columbia. And the kind of general truism was that stigma had dissipated. And I'm curious what evidence they were looking at to decide, nope, we're done. There's no more stigma anymore. And what you've done to say, no, we're not done. There's still a lot more we need to do.
Well, I think it was a great transformation of the mental health system to move from what had been a really intentional, good movement, right? The asylum movement, because the word now has a very bad connotation to us, but it was meant, they used that word specifically because the idea of the time was that the increasing industrialization of American cities was making people sick. So what we need to do is we need to, when they fall sick, we need to get them out of the city, bring them to the country, and let them heal. Okay. The problem was that those places, unless they were the very rich sanatoria, did not have enough staff. We just did not have the number of psychiatrists. We did not have the number of psychiatric nurses that we needed. So they literally became warehouses. So it was a combination of frustrated providers, people with mental illness themselves, and their families through things like the National Alliance for Mental Illness that sort of joined forces. And over a series of about 20 years, we shut down one after another of those hospitals. And so the movement was to community-based care. The reason why that's why they thought stigma had dissipated, because they thought stigma was associated with the asylum movement. The problem is that as they were institutionalizing in the US, we also hit some financial crises. One of them was one of the gas crises. And so the money that was supposed to go into community care and what is called wraparound care actually went to deal with the crisis. And so we have never had a really good and solid community-based care system. Even when John F. Kennedy and his family really sparked the movement of community mental health centers, what happened was, in order to get that legislation through, right, which really should have been for people with serious mental illness living in the community, they had to sell it as something that the worried well could go to. So in its early stages, it really didn't address the needs of people who had been let out of the asylum or people who were coming up in that age between 14 and 25 when they were encountering major mental illnesses. So it was a series of different circumstances that leaves us with sort of a not great patchwork system in the United States. But I think for the psychiatrists, for them, it was like, yeah, stigma's gone because we got rid of the asylums and now we're community.
That's interesting. So the 19th century studies scholar in me really wants to now talk about Mary Todd Lincoln and and all the ways that gender was policed through asylums, etc. But I'm not going to do that.
Well, not only that. Well, and Ellen Dwyer's work here from IU, we actually found data to test some of Ellen's hypotheses from a long-term study of a Vermont mental hospital. before deinstitutionalization, social characteristics were critically important as to whether or not you got in the hospital. And her book was all about how women who didn't perform their wifely duties were often sent to asylums, right? They were bad wives. They were mentally ill. After deinstitutionalization, it really was more the symptomatology about whether you got into that. And the idea that we've eliminated all long-term care facilities, or most of them, is actually wasn't a good idea, because there are some people who really cannot exist in society. They really need help. And for a while, the US moved to this movement of assertive community treatment, where there was this place where people could go on a daily basis if they were having, not if they were just having a mental health problem, but if they couldn't explain things to their landlord, or they really couldn't deal with their money and shopping, they could go there. But eventually what happened with the assertive community treatment was that people said, well, these people are in recovery, so why do we need these? And then they closed them all down.
Yeah. So I'm glad you're sort of talking about US based, because one of the questions we have from someone named Mohammed has to do with how transportable are these ideas to a transnational kind of context? How much do these things have saliency outside of the US?
I think that's a great question. And we asked that question after we did the US, well, as we were doing the US national stigma studies. As a person who was actually trained in cross-national sociology, I wanted to do a cross-national study. And we got an opportunity. And we're to date still the first and only study that's been done with at least one country on every inhabited continent. And this was called the Stigma in Global Context Study. One of the things that we were really excited about was testing a major hypothesis. And that hypothesis was that, and it had come out of the WHO, World Health Organization, that, if only in America we could be more like and using these words that we no longer use, the less developed societies where they're kinder and gentler to their people, then instead of being the mean Great Britons and France and UKs of the world, that people with mental illness would be better. But as a sociologist, I always know I have a good research question when the hair on my back of my neck stands up. And when people would say this hypothesis, I'd say that just doesn't sound right to me. So part of our motivation was trying to get a sense of what stigma looks like around the world. And we did that. And we found that there's no relationship between level of development of a society and the amount of stigma that they had. But we found very few societies we found no societies that had no stigma, right? But we did found variation, and it's kind of a curvilinear relationship with the countries that hit the top of the spectrum in terms of the highest levels were China, the Philippines, Cyprus, South Korea. The place that hit the middle, like the lowest, were, not surprisingly, I think, the socialist countries, right? So Sweden and Germany and those. And then it starts to go up again when you get to the United States and UK. So we do have a sense that there is a distribution, but this problem exists everywhere. And importantly, Mohammed, what's happened is in the last 2 or 3 years, the Lancet Commission, which is this important group that writes these reports for medicine, and they finally turned their attention to mental illness and stigma. And their recent report really highlights the need for a global health approach to reducing stigma, not just focusing on the wealthier nations. And I think that that's really been a change that we've seen over the last 20 years. So I'm afraid stigma exists everywhere. There are places that are kinder and gentler than others. But here in the United States, we're not the worst. So I don't know if that's, I don't know if that's saying a little bit of nothing, but that is the case.
So we have a number of, I hope, Bernice, that you'll actually read the questions on your own separate from this conversation, because I think they require a more thoughtful kind of response from you, perhaps in an email after the fact. Robin Cox in particular is asking some really, I think, compelling questions about how does one check in with somebody that they feel is undergoing a kind of mental health crisis, particularly around paranoia symptoms. I don't know if that's something that you feel that you would want to address in this context. Robin was also asking about differences between kind of clinical and research or medical, right? People who do therapy versus people who prescribe. And are we also wondering if we're facing a shortage of psychiatrists today?
Yes, especially child psychiatrists. Especially as we're recognizing, when I first got into this area, people were never diagnosed with mental illnesses till late teens, right? Now we're diagnosing kids at a much earlier age, and that's important because if you can help them at that age, then their brain pathways will, I don't know. I mean, I don't have the right word. I'm not a clinician. I'm not a biomedical scientist. But there was a study that came out, and I remembered this. It said that in one of the big studies, there were kids with ADHD, and they followed them for like 7 years. And one group, the parents medicated them, and the other one, the parents refused to medicate them. And what they found after 7 years, and they didn't know how to explain this, but it was fascinating. The kids who were on medication actually had more white brain matter develop in their brains than the kids that were not medicated. And what's interesting to me about that, and I've asked lots of psychiatrists about it, and they don't know the answer. But what's interesting is the white tissue in the brain is the part that connects the pieces of the brain together. So I think we have evidence that you can change brain pathways if you get to them earlier. So I can't say more about that because really I am not somebody who is fluent in the biomedical or psychiatric sciences. I know enough to be able to do my work. But I did want to say about this, about the Institute, for example. Yeah, we do a lot of different things at the Institute. We focus on mental illness and stigma in all areas. We did some things in the state of Indiana. We did this person-to-person health interview study where we looked at the effects of COVID-19 on residents, a representative sample of people in Indiana. We are doing work in dementia, looking at how the kinds of social network ties that people who are having cognitive decline have and what that does to slow the cognitive decline. If you have, one of the things that people think is, when somebody has dementia, you need to protect them. But in fact, and we call that bonding capital. But what we found, this is my colleague Bria Perry, what we found is that it's people whose ties, who are brought into the community, who go to their church and keep singing in the choir, or they bring together a number of people with dementia who sing songs from their youth. They're the ones whose cognitive decline is slowered during that. We also do other things. We're not just a mental health institute, although that's one of our primary things, but we also do work on the healthcare system. We have a group of excellent health economists that work with us. We do work on, we have quite a good research agenda on suicide. We do things on reproduction and HIV. Trying to think what other things we do. We have a lot of different studies. We do a great deal of work on addiction, not just stigma, but we do stigma of addiction. We work with a group called Shatterproof on that to help them with the change that they do. And they are particularly focused on the workplace for the people who asked about that. So the Institute is for the socio-medical sciences. So whatever our faculty are looking at, our goal is to try to help to understand how these non-medical factors help. So one of our biggest areas of research is mental illness and substance use disorders, but it's not the only one. And so it's the scientists who want to work with us in a collaborative framework. They are welcome to the URSA. Okay. All right.
So I realize we only have about 5 minutes left, and again, we have some just sort of information questions I think that are being asked. But I actually wanted to learn a little bit more about the work you're doing with the cults, and I think it's a fascinating way to see intersectionality and interdisciplinarity in action. So, of course, one of the things I think about our concussion studies as it relates to mental health, to behavior, to masculinity, to organized sports, to things like football in particular, and how much sports, particularly football, becomes a cross-section of a lot of different kinds of identity.
Mhm.
And so I really kind of wanted to close this down by asking you to say more about what are you doing with the Colts and what other kinds of research questions are emerging from the work around stigma that when you tuck into one, all of these other kinds of possibilities open up.
Yeah. Well, I think it's no secret that when the Colts picked kicking the stigma, it was not it was not by accident, right? I think many of you know that their family has been affected by alcohol abuse and by drug dependence, and it's had an implication, mental health implications on the generations that followed. And so that's why they picked this. This is very personal for them, right? This is really where their heart is. But I will say for the Colts that they see themselves as stewards of the state. And so while the philanthropic arm of the Colts does focus on kicking the stigma, they define it in a very broad way in the sense that, you know, they build playgrounds, they do backpacks in the summer. They're now doing this thing with Martha Hoover, who did Cafe Patachou. They're now bringing healthy foods to the schools and teaching the cafeteria people how to make healthy food. So I think that they understand that mental health really has a broad foundation where if you help people who are suffering in one way, it can help alleviate their suffering in another way. We know that one of the greatest predictors of mental health problems is, in fact, poverty. So I really like the way the Colts do this. They always did those kinds of things, but now they are sort of bringing their own sort of issue into it as well. And I think doing it in a very good way. And I think that the NFL is really stepping forward on mental health. I'm working with a group now that's the NFL Hall of Fame. They're trying to do a mental health concert because they said when they called and asked me if I would help, and they said, there are things for, there's farm aid, and there are things for heart, and there are things for breast cancer. Why does nobody stand up for mental health? And they said they were going to try and do it. Let me say, it's been very difficult because I always say mental illness and stigma is stigmatized work. People in the end, they don't give their money as freely to support these kinds of things as they do other things. And even like America is very generous when it comes to like personal things, like, little Charlie needs a new kidney, right? Americans are incredibly generous. But somehow when it comes to mental health, sport isn't quite there. And that's true whether you're talking about the government or the national institutes, because, the prevalence of mental illness is 1 in 5, and the presence of cancer is about the same. Cancer Institute, which is making phenomenal progress, gets at least 10 times the money that mental illness gets. That reflects the stigma that still exists in our society about these health problems. I did want to say too, I think leaders do understand that about homelessness. I don't think they know what to do about it. There are programs called Housing First, and those programs are one where they believe that people have to have stable housing before they can deal with mental illness, food insecurity, getting a job, etc. I also wanted to say, I haven't been involved in the Ask campaign, but I'm really happy. Oh, and Alan Smetzer. Oh my goodness. Alan Smetzer was one of the most important psychiatrists in Indianapolis from my point of view. So Alan, hello. When my work gets declared a success, I can retire and get into a rocking chair and enjoy the rest of my life. I'm afraid that's not going to happen, but Alan, so happy to see you on board. And then I'm so happy for Martha, who found that her experiences here at Bloomington when she actually had a mental health problem herself were taken care of. I do want to say that we have really worked hard here to improve the mental health services. We now have something called timely care that we're testing out, which is somebody asked about a helpline. There isn't one here at IU, but what there is timely care. All students, they can register for it. 2:00 in the morning, they're having a problem, they can call timely care. You should also know that the state of Indiana is working really hard to do 988, which is for mental health crises, not physical health crises or law issues. And I think that's really important because I don't think that people with mental illness fare well with typical first responders. Although I will say that many of the first responders, particularly the people, the EMTs, are really stepping up and learning more and more about how to handle people who might be in a psychotic break. And I don't know who you are who said, did we ever talk about Thomas Szasz and the myth of mental illness? Were you in my class? Because we do that. We still do not only Irving Goffman, but yes, I sort of bring out that at one point, the psychiatrist, right? Now, Thomas Szasz was a psychiatrist, but the book that really fleshed out his idea was written by Thomas Sheff, where he developed an entire theory of how mental health symptoms get socially constructed. But I will say this, there was an argument in the 70s and 80s about whether or not people stigmatize people with mental illness because they behave weirdly or because of the label. And the myth of mental illness said it's just a labeling problem. Our research has shown that both the label and the behavior have independent effects in how much people are stigmatized. So that was kind of a nice thing to be able to resolve in the scientific literature. Brenda, back to you.
Well, thank you. I mean, honestly, this is really fascinating. And to me, it's exactly the value of a liberal arts education. And who better than professors to actually be learning in these moments, right? Because it's precisely drawing on all of these kind of large, complex systems and conversations that are very much a part of our lives. Vanessa, I want to turn it back over to you to offer final comments.
Thank you again for joining us and participating in this evening's live stream. I would like to personally thank Professors Pescosolido and Weber for their time and expertise. We are grateful to you all. I would also like to acknowledge the IU Alumni Association and its members for assisting with tonight's event. Finally, I should recognize that efforts like this would not be possible without the support of donors who understand the value of a liberal arts education. If you would like to support programs like tonight's presentation or other opportunities that connect alumni and friends with the College of Arts and Sciences, please consider making a contribution to the IU Bloomington College Alumni Engagement Fund at the Indiana University Foundation. We look forward to connecting you with the college and each other again soon. Until next time, please take care.